Thank you, Dr. Srivastava, for your kind words, and I thank Dr. K.K. Agrawal for inviting me here to discuss this topic that is so close to my heart. I bring you compliments from Indraprastha Apollo Hospital, New Delhi, where we have a setup dedicated to the treatment of obesity and diabetes. And all of us know that diabetes, and Dr. Mittal's previous talk has made my topic so easy to discuss. But still, despite all best control of diabetes, we know that diabetes is a chronic progressive disease. Despite good pharmacotherapy, good control of blood sugar, the patient continues to develop macro and microvascular complications in the form of increased cardiac risk, increased stroke-related deaths, increased damage to the kidneys and renal failure, blindness, and lower limb amputations. So even if you do best pharmacologically, the diabetes continues to progress and have its pathological changes in various organs. The question is, can diabetes be completely cured? I know when I'm saying this, I'm giving this statement, or I'm asking this question, it's a goal which has earlier been almost unheard of, because whenever we talk of diabetes control, but today we are going to have a look into the future and to what we have, the information and the experience that we have gained till date, that can we cure the diabetes. As Ambrish also said, diabetes and obesity are two very commonly found conditions. They are quite commonly associated, and both of them are very dangerous. And Ambrish also puts it in wonderful data to show that about 61% cases of diabetes are because of overweight. And 87% of the newly developing cases of diabetes are because of overweight. If we make all patients normal weight, then we can get rid of a large number of patients of diabetes. And diabetes is only one manifestation of obesity, or what we call as a morbid obesity, where obesity becomes a disease by itself. It's just one aspect. There are so many other aspects: respiratory, heart disease, cancers, osteoarthritis. But today we'll confine our discussion only to the diabetes as it relates to obesity. Now the question is, how obesity causes diabetes? What is the relationship? What is the mechanism? Freza put forward his observation that intra-abdominal fat causes increase in the concentration of plasma free fatty acids, and these increased free fatty acids decrease the insulin sensitivity both in the muscles, which are the major utilizers of glucose, as well as the liver, which is another important organ that utilizes glucose. And because these organs becomes resistant to insulin, so the beta cells of pancreas increase insulin secretion to attain higher level of insulin so that these organs can utilize glucose. Slowly these beta cells, they work more, they get atrophic, they get dysfunction. And when these beta cells start failing, then diabetes develops. Actually, this insulin resistance is quite a core issue to almost all diabetics, at least in the majority of diabetics. And insulin resistance always exists in majority of diabetics. So when beta cells fail, diabetes develop. Now, Ballantyne put another theory that there is an adipo-insulinar axis theory. He convinced that these fat cell masses, this increased fat which amounts to 30 to 40 to 50 to 60 kilograms in a patient with morbidly obese person, it regulates the glucose and insulin metabolism by releasing certain adipocytokinins. And some of these adipocytokinins are leptin, adipolectin, and resistin. And they create, they promote, and they regulate diabetes. If we see the pattern, insulin is not the only hormone that is related to diabetes. It is most commonly talked about. Insulin levels in diabetics are decreased, as you can see here. But there's another hormone, glucagon, which we almost never talked till very recently. And these glucagon levels are also important because in diabetics, these glucagon levels are increased, while in normal patients, these glucagon levels are decreased after the meal. And we'll see the next few slides what is the role of glucagon in the development and treatment of diabetes. The first report that surgery can cure diabetes came way back in 1955. Friedman did a subtotal gastrectomy for gastric cancer, and he observed that his patient after a few years became non-diabetic, and he maintained his non-diabetic status. He reported it in 1955, but the medical fraternity perhaps was not mature enough to understand the significance of this report, and this report almost went unnoticed when, after 40 years, in 1995, Pori et al. Reported when treating patients with morbid obesity, and they reported in 133 patients, 83% of patients in whom they had done a gastric bypass became non-diabetic from diabetic in a 14 years follow-up, which means this effect of surgery on the diabetes was maintained in the long term, and most of them, 83% is a huge number, these morbidly obese patients who were diabetic became non-diabetic. There was another report which showed that many patients who were on insulin earlier, they became completely non-diabetic. Patients who were on OHA, they became completely non-diabetic after obesity surgery. And patients who are on diet alone or no treatment also became completely controlled. So obesity surgery has a very great impact, not only on the weight loss, not only on reducing obesity, but also in improving and curing diabetes. And then came the current era of laparoscopic surgery, when Whitgrove did laparoscopic gastric bypass Roux and Y, and that has really stimulated and changed the entire scenario, because that bariatric surgery, which was very morbid earlier with a long incision, poor wound healing, high complication, became being done by minimally invasive access. Patients were being discharged in 3 to 4 days. All the morbidity disappeared. And even in laparoscopic bariatric surgery, Whitgrove reported that 24 out of 100 patients had diabetes, and at 30-month follow-up, 22 of these 24 patients became completely non-diabetic. So bariatric surgery is not surgery which only reduces weight, which only makes you healthier, but it takes away your diabetes. And following that, there was a large number of reports, there was a huge number of reports, almost all confirming that that bariatric surgery can, besides reducing weight, can improve diabetes or can cure diabetes. But the most important evidence came from the meta-analysis of 136 studies of bariatric surgery involving 22,000 patients. And in this study, Bruchal et al. Showed that 76.8% patients who were diabetics earlier became non-diabetic in the long run follow-up. And another almost 10% of patients, the diabetes improved, the patients shifted from insulin to oral hypoglycemics, or their dose of insulin decreases. This was a landmark study which established beyond doubt, with a study of 22,000 patients, that in morbidly obese patients, bariatric surgery can completely cure diabetes in a great majority of patients. Diabetes was again only one of the aspects that this surgery was improving, but we will confine ourselves to diabetes. And this is what the bariatric surgery does. You can see patients lose large amount of weight. Dr. Amrish Mittal was discussing about the newer therapy, pharmacotherapy of diabetes with a weight loss of 8 kilograms or 10 kilograms. But we bariatric surgeon, when we discuss, we don't talk about 10 kilograms or 12 kilograms. We talk about 40 kilograms and 60 kilograms and 80 kilogram weight loss in our patients, which completely changes not only their appearance, but also their metabolic functions with so many organs involved. And you can see this patient losing about 74 kilograms in 2 years follow-up. Or this used to be my heaviest patient till 6 months back, weighing 206 kilograms, his wife was almost ready to divorce him, and now after the weight loss surgery, he has been living happily ever after. This patient came from Dubai with the insulin requirement of 160 units per day, and after gastric, and despite that his sugars were not controlled, and now his HbA1c is almost in the normal region with just about 30 to 35 units of insulin every day. We get a fair share of patients coming from overseas because of the good quality of treatment at much lesser cost. But please remember that this weight loss that you are seeing in photograph does not happen in a day. It happens slowly. We don't remove any fat from these patients. We only make certain changes in their gut so that they start losing weight. Like this lady lost almost 32 kilograms in 3 months' time. She sent me a photograph at 8 months, having lost 42 kilograms. She sent another photograph at 11 months, losing 54 kilograms. So the weight loss is slow, the weight loss is gradual, the weight loss continues for about an year and a half. And this is when she came for her follow-up after 1 year, having lost almost 50% of her weight. So the question is, how this weight loss surgery is helping in curing the diabetes? As you saw in these photographs, weight loss surgery causes weight loss. That is one mechanism, because we know that weight loss in all diabetic patients will improve diabetes, and all diabetologists suggest their patient to lose weight. And weight loss surgery decreases the weight drastically, decreases the component of the fat in their body drastically, so makes all those changes, alters all those bad effects of fat that were happening earlier. Now, besides losing weight, these patients are eating less food. So when they are eating less food, obviously the sugars do not go as high as normally it was. And that's how they reduce weight and improve diabetes. But when we were following these patients in the post-operative period, it was noticed that the blood sugar level gets normalized much faster than the weight loss. Weight loss takes months and months, but the sugars sometimes get normalized in 2 weeks, 3 weeks, 4 weeks, sometimes even before the discharge. So weight loss is not the sole factor which is improving diabetes in patients with gastric bypass. There are perhaps certain other mechanisms other than weight loss, other than decreased food intake, which are contributing to improvement or amelioration or remission of diabetes so fast in 2 weeks, in 4 weeks, or in 6 weeks. And if we see our gastric bypass, what do? We make a small stomach pouch. We bypass completely the stomach, the duodenum, and the proximal part of the jejunum, and anastomose the ileum to the small gastric pouch. So what is happening? When the patient eats food, one, the food is not going to the stomach and the duodenum. So we are bypassing besides stomach also the duodenum. Secondly, this undigested food is going straight from the gastric pouch to the ileum. So this undigested food is getting delivered fast into distal part of the intestine. So there are these two things which we are doing in the gastric bypass. One, we are eliminating the proximal intestine. Sorry. So that is a hypothesis of proximal intestine. Two, we are delivering undigested food into the distal intestine. So there are two mechanisms by which perhaps this surgery is helping us in improving diabetes. And there what comes the theory of incretins and anti-incretins. This theory emphasizes that when the food passes through the duodenum, there is secretion of certain hormones which we call anti-incretin that increase the tendency to diabetes. And when the food is diverted and reaches the distal part of the small intestine, there is secretion of certain hormones which we call incretins, which improve diabetes, which help in amelioration of diabetes, which cause increase in the insulin secretion, which increase the sensitivity of the peripheral organs to the insulin. And that's how the diabetes is helped in obese patients by a gastric bypass. And that is what happens. This is the duodenum. When we take glucose, this glucose is absorbed from the blood. This absorbed glucose acts on the beta cells of the pancreas and increases insulin secretion. But besides this, what is happening? That this glucose in the intestine, in the distal intestine, also causes secretion of incretins, and these incretins cause increase in the insulin secretion. This is an age-old theory, but this is a newer theory which has been found out recently when we have observed that the patients with gastric bypass improve their diabetes. There are, I'll not go into detail, but there are K cells which produce incretin hormone called as GIP, and there are L cells which produce another hormone called glucagon-like polypeptide 1, and that is how the role of glucagon comes, because these hormones mimic glucagon and they create certain changes on secretion. They increase stimulate the pancreatic beta cells to increase insulin. They increase insulin sensitivity of the peripheral organs. They inhibit glucagon secretion. They increase the number of beta cells and they delay gastric emptying. So by all these mechanisms, these incretin hormones improve the diabetic status, cause remission of diabetes, cause improvement of diabetes, cause normalization of blood sugar level. And this theory is called as an entero-insulinar axis. So insulin is not just a disease of the pancreas. It can be affected by making certain changes in the intestine, which in turn have their effect on the pancreas by entero-insulinar axis. So diabetes is not only a disease of the pancreatic organ, it's also a disease of the gut, which modification of the gut can improve diabetes. Now this is all happens in obese patients, in morbidly obese patients, which are 40, 50, 60, 70 kilograms overweight. The question is, does this intestinal-insulinar axis apply to non-obese individual? When that question came, Rubino from the USA did an experimental study. He selected certain kind of rats which are modeled for spontaneous non-obese diabetes. And in these patients, he created some changes. He bypassed the duodenum, he bypassed the jejunum and anastomosed the ileum directly to the stomach by creating same changes that were being performed in the gastric bypass without changing the stomach, only inducing changes in the intestine. And what did he find? He found the majority of these rats who were non-obese and diabetics became non-diabetic just by making certain changes in the pancreas, and that confirmed the theory of incretins and anti-incretins. And another surgeon from Brazil, Dr. Arodi Pavlovich, is one of the pioneers in bariatrics, in diabetic surgery, and he has the largest experience of performing diabetic surgery in the world. And he's coming to Hyderabad next month, and we're having a meeting with a select 15 surgeons in this country. He took out the ileum, the distal ileum, and transposed it in the proximal part of the intestine, so that the same theory of delivering undigested food to the distal intestine is done without making any changes. And he did it in patients whose BMI was less, whose BMI was 21 to 29, and he found that 80% of these patients on whom he just made these changes in the intestines, their diabetes completely improved. So this surgery is called ileal interposition. So to summarize, Chairman Sir, diabetes can be improved by many ways after surgery. The standard thing of decreased intake of food, gastric restriction and energetic imbalance holds true, but now there's a foregut hypothesis, there's a hindgut hypothesis. By bypassing the duodenum and by rapid stimulation of the distal intestine, by undigested food, we can make certain changes, certain hormonal changes, which have their effects on the pancreas, which have their effects on the insulin secretion, which have their effects on sensitivity of the peripheral organs to insulin, and the diabetes can be cured. So from bariatric surgery, now we are marching towards diabetic surgery, which has been a tremendous change. And this surgery is done by laparoscopy with small tiny punctures. When these patients of 230 kilograms, 240 kilograms come and stand in front of you, you really sometimes feel scared to operate upon these patients. It's a big challenge to do surgery on these patients, because these patients come in different shapes and different sizes. To fix up these masses of 200 kilograms of patients on the operating table when you are going to operate them is not easy. To shift them from the operating table to the trolley is not easy. To make them, to anesthetize them, to make them breathe after surgery, it's a big teamwork. It requires a coordinated effort. It requires the infrastructure. To put your laparoscope through these thick layers of fats is itself by itself a tremendous task. And the surgeon has to be prepared. If the surgeon is not properly trained, if the surgeon is not properly skilled, entering the abdominal cavity and with the mass of fat, difficult to identify all the organs, you might be having certain delusions and you may not feel confused as to what you are seeing. But when you take up the challenge, you really feel very happy that you are not only helping these patients in improving their weight, but you're also helping in patients getting cure of a disease which is so far was considered only as a controllable and not a disease which was curable. In 2007 in Rome, there was an international summit on diabetic surgery under the auspices of 20 major international scientific societies. And they came to a conclusion that today we stand in an era where perhaps diabetes might be a curable disease. And they made certain recommendations. And the recommendations were that with a BMI of less than 35, gastric bypass will cure diabetes. It should be applied now even to patients with a BMI lesser than 35, from 30 to 35. But for thin individuals, for not so obese individual, either a duodenal gel bypass or an ileal transposition with sleeve gastrectomy in an investigational setup should be started in major centers with larger volume to answer the question whether diabetes is a curable disease. And as we stand here, it's a very provocative statement, but the future looks very bright. And perhaps we are walking into an era where we might see more and more patients getting cured of this disease, which otherwise they would have carried their lifelong, and despite good control would have stroke, would have heart disease, would have amputations of their toes or eye damage. But we have to go in a very controlled, very disciplined fashion. We don't have to just to jump. The protocols have to be redefined. Which patients initially we should offer surgery should be identified. The norms and the regulations should be identified. It is only then that we should apply this surgery cautiously and carefully. And to conclude, a fairy godmother can change a chariot, a pumpkin to a chariot for Cinderella, but there's no fairy godmother today which can change fat into protein. If you have to change fat into protein, you have to work, you have to exercise, and you have to exercise. And the concepts in life are changing. In the old cave age, it was the weak and the thin and the feeble which would worship the strong and the burly. Things have changed now. Now it's the big and the early and the grotesque which worships the thin and the strong and the beautiful. Thank you very much.